The specific brief around this is neurology and sales, so I'll try and talk through what we've got with that. And if my slide would move on, that would be lovely. So, bit of background first. What is multiple sclerosis? What is the MS register? And some sort of hint about the work we do with SAIL, which I think many people don't think we do that much work with SAIL, but I'll try and give you a hint. Multiple sclerosis is the commonest non-traumatic disabling disease to affect young adults. That's a bit of an oxymoron. Most people think of MS, they tend to think of older people as having it, but of course, most people are diagnosed before the age of 50 in MS, although we are seeing that change a little bit as well. And it affects about 150,000 people in the UK, or 2.9 million people worldwide. The incidence of it does seem to be increasing around the world. We could speculate for the reasons why, and I'll try and touch on some of them, but it's a massively disabling disease for those people that get it. I'll run you through the disease course in a minute, but it impacts both physical and cognitive ability. So it's not just a physical thing that affects your walking, it can actually affect your mood, memory, and information processing speed as well. The disease itself has a process of inflammation followed by demyelination and eventually axonal loss. Owen could give you more detail on that than I can, but I'm going to touch on that too. It initially starts out as local, but it goes on to have more widespread impact. So what we're looking at briefly is if we look in lymph nodes, then antigen-presenting cells and T cells interact. They cross the blood-brain barrier, become permeable to leukocytes, and then you have an interaction between these T cells and macrophages and microglia, which cause an issue with not only myelin, but myelin-producing cells as well. And now if that process goes on long enough, not only is the interaction between the myelin sheath around the nerves affected, but the actual axons, as I talked about in the last slide. So that's a disease of the central nervous system, mostly, but that's sort of in a nutshell. It's far more complicated than that, but that's my idiot's view of it. Demyelination looks like this. If you think of an electrical wire with the insulation stripped off, that's effectively what we're talking about it. Don't do what I did and ask AI to try and draw you some sort of generation of what that looks like. It looks quite pretty if you look in the top right corner to begin with, but you can see it's made up some words, and I'm not quite sure what the AXDs of Ronvier are, but it's still quite a pretty animation, so I've left it there for the purposes of that. In terms of disease activity, MS is a catch-all term for a number of phenotypes and sort of subconditions within that. But just to try and paint you a picture of what that looks like, is that you have the concept of MRI. That's how we diagnose MS mostly these days. There are some other ways of doing it, but the primary method of diagnosis is via MRI. And then you have other things that you can measure clinically about what's going on with the patient, those being lesion load, which is what we T2 lesion load, which is what we look at with MRI. Patients have relapses, and then you have brain volume loss as well. And if I draw some of the other things on the graph here, you have a preclinical phase, a clinically isolated syndrome phase, relapsing remitting disease, and then secondary progressive disease. And if I continue to draw my graph here, you can see as the T2 lesion load is done through your repeated MRI scans, then lesion load increases over time, which is kind of what you'd expect. But if I draw the graph on for the sort of the preclinical to secondary progressive phases of the disease, and hopefully you can see my mouse cursor, is that there's a period where not a lot's going on, but there's obviously some response within the system to the point you have a relapse, at which point that's clinically isolated syndrome. You haven't had multiple relapses at that point. You move on from there. However, the disease may go on and eventually turn into relapsing remitting disease, which is multiple relapses, not just the one we've observed before. And after a period of time, that transitions to secondary progressive disease, where you may not see any relapses. You may still see the odd one, but what you have is this gradual increase in progression going on. I've left one potential phenotype out here, and that's primary progressive disease as well, where you just see that gradual increase in progression, or sometimes quite rapid increase in progression for patients over time as well. So that's sort of a nice snapshot of what the disease activity looks like. And obviously, this period of time is variable for people. In some cases, the disease is more aggressive, in some cases, less so. So that's great. But where does that leave us in terms of routine data? Well, there is an ICD-10 code for multiple sclerosis. In the inpatient and outpatient stuff, it's G35. For general practice, it's the read code of F20. But the problem within routine data is that a lot of the other things, as the previous speakers have said, just aren't present in routine data for us. Disease-modifying therapies are mostly prescribed by consultants, specialist consultants in the United Kingdom, so therefore aren't prescribed by a GP, so won't appear within SAIL. MRIs are not generally available, and then that really fine-grained outcome data, and specifically EDSS and others, are also not available as well. So it's a fairly blunt instrument if you're immediately sort of trying to do stuff with multiple sclerosis within SAIL. So what you do to combat that is you launch a disease register. And in this case, I'm going to talk about the MS register, but it's the obvious thing. And really, it's a disease platform is what we've created by this point. And classically, what we're known for on the MS register is the collection of patient-reported outcome data, a little bit more on that in a minute, and then clinical data from, at this point, 55 NHS sites across the UK. We are truly a United Kingdom multiple sclerosis register, not just a Welsh one. Laterally, we have added more data to this. We have a close relationship with the tissue bank, so we have actual pathology data as well accessible to us, some genetic data from studies that are ongoing, and increasing amount of MRI data from initiatives like Pinpoint MS, which is bringing MRI data and sequential MRI data into the registry as well. And then, of course, we do some work with SAIL. More on that in a second. But that disease platform is an ongoing thing where we collect information about all aspects of the disease and beyond these days. So that's where we've moved to. Briefly to talk about the patient-reported outcome data, we obviously get a lot of this into our own SERP, the MS Register SERP. So that's things like demographics, outcome scales such as the MSIS and MSWS, EQ5D for measuring quality of life, a measure of mood in the anxiety and depression scale. One of the most disabling features of MS is fatigue, so we capture the fatigue severity scale as well. The course of the disease, as I showed you in the previous slide, it changes over time. An outcome in Web EDSS, comorbidity, symptoms, medications are important as well, lifestyle, and then free text experiences. We encourage our participants to give us a bit of journal as things are happening over time. We also collect a clinical minimum data set where we have demographics, MS type now and diagnosis, dates, relapses, disease-modifying therapies are incredibly important and an area of MS that has only grown in the 15 years I've been working with it, whereas we're only a very limited number of beta interferons at the start. We've now about to move into a phase of BTKIs and other drugs that are actually able to do something about some specific parts of the disease. And we capture the EDSS, current symptoms, pregnancy and smoker. EDSS comes up a lot in MS and my sort of standard, it's not a joke, but it's not a very good assessment. It runs from 0, you're perfectly fine, to 10, you're dead. And there's a lot of these assessment scores that aren't great. If you think of the Glasgow Coma score, it has a similar problem. You still manage to score 3 on that when you're dead. So however, these tend to be the benchmarks by which many of these diseases are scored, rated, and outcomes are compared against each other. So you've got to work with what you've got. The MS Register itself has been pretty successful, I think. We have over 60 references at this point, not just from us, but from other. We obviously allow other researchers to make use of our data in the same way that the SAIL Databank does. So that's a few just there to say what's going on and aren't we clever and we've done great things producing it. But that's not really the point of what I'm talking about today. I'm meant to be talking about what we can do with SAIL. So just to sort of hark back to something, what causes MS? It's all very well saying it's a massively debilitating disease, but what causes it? And the thoughts are there's definitely a genetic component. There seems to be an environmental component. There's an infective component. And what else? Does it matter when you were born, when you were conceived? Do pets have anything to do with it? And that's not just a throwaway thing. If we look back to the end of the 70s here, they genuinely thought that pets had a massive involvement in MS. And that's not just an excuse to show my dog. There's also the thought about where you live in the world. It seemed that MS was more prevalent towards the poles. So we saw a lot of it in Europe. You'd see it in Australia and places like that, and less around the equator. So there's the thought that it's something to do with vitamin D. It's definitely got something to do with how early genetics were moved around by Vikings as they carried out in their day-to-day activities. And we see that sort of genetic history being part of what's going on. But an interest in what happens with vitamin D climate-wise and where you can be was definitely a feature towards the ends of the 2010s. So we thought we'd try and have a look at that within SAIL to see what we could do. So we identified a cohort only using PEDU, so patient episode data for Wales. I also think that should be a Welsh word. Using the G35, people who'd had episodes, so that they had a G35 code lodged between 2002 and 2013. We linked some census data to get LSOA to identify coastal areas. We did our best to bring in some sunshine stuff across Wales from data with the Met Office. And then we age banded our participants into 5-year groups to do a month of birth analysis because we wondered if that was a true thing as well. So we did it. Here's a nice map on the left and the right. On the right, you've got sunshine hours per day. The coastal areas have higher sunshine, probably not that surprising. And on the left, you've got incidence of MS, or cases per 100,000 of population. I'd stress to say we didn't do a very good job with this paper. I mean, it's still a thing, and the sunshine work is interesting, but it's not the greatest piece of work in the world. We did, however, manage to confirm that the month of birth effect exists within SAIL as well. And as you can see, if you look at April here, you have far more MS births take place in April than any other month in the year. We see this more broadly in the MS register as well. So it's definitely a thing that MS births are more common in April. People still get MS every other month of the year, but that's just of interest. We also managed to calculate a rough incidence, and incidence in Wales at that point in 2016 when we calculated it was 9.1 per 100,000 people, which isn't a million miles away from what we see in other countries, particularly Western countries, but might have been a little bit high. So that was a useful piece of work to do, if anything, just to give us an idea of what was possible with SAIL, what data sets we could link to and sort of go forward with. However, as I have stated, that's just using what was in SAIL already. We obviously have other resources. We have what the MS register gives us in terms of what I've already told you about collected, but it also potentially let us solve a problem. Every time I've stood in front of a group of doctors and talked about capturing patient-reported outcome data from people with MS, somebody is eagerly about to stick up their hands and say, but how do you know they've got MS? So I got a bit fed up with that, and I thought maybe this could also be a way to validate our cohort of people with MS too. So to that end, we carried out this paper, the algorithmic approach to finding people with MS in Wales using routine data. So as I said already, the approach in the previous data paper wasn't very comprehensive. It didn't take into account of GP or outpatient data or any of the other data sets that we could have made use of. And we could bring in other data sets, of which the UKMSR was one. I won't go into this in too much detail, but if we look at a consort diagram for how we included people within our algorithm, which we've given the catchy title of SAMSA, that's not a Game of Thrones reference, it's got an M in there, not an N. And we published this on GitHub as well as in the actual publication itself, so go and have a look at it. Of the 4 million or almost 5 million entries we had within SAIL, we restricted that to those born between 1970, those with records between 1970 and 2020, born after 1910. That immediately dropped almost 2 million people from out of our cohort of interest. And then when we carried out linkage to these other data sets, which we won't go through because you folks know what they are, we were managed to get that number down to a more attainable 2.7 million, almost 3 million people. So that's not bad. Of those, 8,570 had an MS or demyelinating code. Now, if I just zoom in on this a little bit, we were able to categorize them into two different ways. Those with other demyelinating diseases, based on the codes that you see there from G35 and F20, so not MS, of which there were 2,260. And then those that looked like MS, where we were able to see the presence of those G35 or F20 codes. If they didn't have them, we excluded them. If they were present, then we'd consider them. However, we then go on to look at an actual onset date and a number of events, because just having one MS event wouldn't be good enough, and we'd want to know that there was some sort of precursor condition in the decision box there as well. So if they qualified, they had an onset date of greater than 6 months, were in the WLGP and had 3 MS events, then we called that an MS case. So we're able to identify 6,194 living cases of MS within Wales. Great, so that's fine. We've got maybe an algorithm that can identify people with MS. Let's bring in those other data sets. So we brought in Cardiff clinical data. So this is the South East Wales MS cohort, and we loaded the UKMS register data as well into the SAIL databank through the file 1.2 process, as we've talked about, applied our algorithm, and that gave us this, where we could calculate our sensitivity and specificity of our algorithm. So of the 713 Cardiff patients loaded, we managed to identify 96.8% of them with our algorithm, and of the 836 Welsh MS register participants loaded, we were able to identify 96.7% of them with the algorithm. So that's pretty good. Specificity you can do. We know what the rough area of Cardiff is. We know how many people live in the Cardiff area, 477,372. So we can actually work out specificity. The MS register we can do that with, but this is a pretty good indication that our algorithm's quite sensitive and quite specific. And as you look across for the age of the population and the age at diagnosis, which we're also able to calculate with this algorithm, it's pretty close from what you'd expect from clinical practice. So this was good. We had an algorithm, and we're able to calculate a better incidence than we did the first time around of 7.48 per 100,000, which is far more in line with what we were actually expecting. Awesome. We've got a hot new algorithm. It's smoldering there in the corner. What are we going to actually do with it? Well, this is moving on to what we're going to do next rather than what we've done before. And I think it's important to talk about infection. Infection is probably one of the most important things other than genetics within MS. What you're looking at here is some work carried out by Bjornovic and Ashirio in the United States military population, where they had a large population of young, fit people who were being recruited into the military, and they took blood out of all of them. as they were joining it, and then a number of points post them joining the military services. And what you can see is that almost everybody who went on to have MS had a large number of Epstein-Barr virus peptides in their blood. Actually, 99% of the population that they tested did. And if you go on to see when they seroconverted to having MS, this was notably different for the people who didn't go on to have MS compared to those that did, both for Epstein-Barr virus and for CMV as well. So what you have here is a bit of a smoking gun when it comes to an interaction between people's genetics and an infective process taking place. Still, you need to think about environment, but of course, the introduction of Epstein-Barr, which you may also know as glandular fever, could be brought into the environment by a sibling or by putting lots of people about the age of 18 into a room together or to share barracks or things like that. So what could we do with SAIL becomes the question. Or is it possible to replicate something like the Asherio paper with the data that we have in SAIL? Kinda is the answer. We're obviously still working on this. There's some things to wrinkle out. This is fairly early data. It has been through file out properly, so I feel fairly comfortable showing it to you. But just to talk about this a little bit, obviously we're able to look at more than just one thing, as the Asherio paper did from Epstein-Barr. We're also able to look at infective mononucleosis. So infective mononucleosis you could think of as bad Epstein-Barr. You've actually had to have a hospital admission for it. And if you look at our lines here, where you have the black is the SAIL is the rest of Wales, blue is other demyelinating diseases, and those with MS. The incidence of those with MS from birth to infected mononucleosis is much higher. So we've definitely got some sort of signal here that there's something going on that we're able to replicate from what we saw with the Asherio here. However, you do get EBV testing done within the community as well. If it's bad enough to go on, people get tested, and you can see the same thing going on here. Here is population of Wales with the black line. Something is happening with the gold line, which is people with MS that they go on to, go to have MS, as well as those other demyelinating diseases that we see too. We've also looked at CMV and VZV. As I say, we're still thinking about this because there's probably something wrong here, but it's certainly something worth considering. But it sort of proves that interaction between infection and genetics. And again, if we look at those with MS who go on to have this, it's happening at a much younger age than the general MS population. So the numbers are low, but having infective mononucleosis may well translate to bad MS, which could give us that younger age of diagnosis as well. So that's quite interesting. It also makes us think really about what I was saying a minute ago about the pathogenesis of MS, that what's going on here. So you've got a genetic background and you introduce EBV and you have a relapse, fine, and then you go on to have a progression event. That's probably multiple sclerosis. However, what happens with these other things? I already talked about clinically isolated syndrome. There's also a phenomenon called radiologically isolated syndrome as well, which is the same, but you're just isolating it with MRI scans, which obviously have some sort of spontaneous viral or anti-TNF related event going on as well. If they don't go on to have a further change, that's one thing, but you also have this other category of demyelinating diseases like NMO, which is neuromyelitis optica, or a myelin oligodendrocytes glycoprotein, MOG or MOGAD. And there's further changes. So we think maybe this is the pathway to looking at these non-MS demyelinating diseases as well. It's an interesting way to consider it. One last thing just to talk about that we're sort of in fairly active thoughts about at the moment is our community of people with MS are very interested in in ethnicity characteristics, deprivation, and things like that, as are we all in researchers. And involving people from other ethnicities is really difficult. Or not really difficult, but people are underrepresented in those populations. So it would be important on a nationwide level to establish if there is truly a deficit in a recruitment of people from other ethnicities into things like the MS Register or the representation in research, and see if that is reflected, from our local things within the MS Register to national things. So we did a little bit of work with that. And we've also just started looking into that across Wales because it gives us the ability to do that. So we have linked our algorithm, brought it into SAIL, linked it with ONS data, census data as possible. And I'm not going to dwell on this too much other than say it's kind of a problem that we're looking at the moment, where if you look at the exclusions we've got for things going on here, starting with our population of Wales for 3.1 million, we lose almost 500,000 people at the point where we carry out linkage between the ALF1 key. We're trying to do something to improve that. We've been in discussions about it. We think this is a bit of a problem. If we're going to talk about 100% nationwide coverage for something, the first time you show this to anybody, they're going to go, hang on, you're losing, quite a chunk of the population at one of the steps before you get to the point of actually being able to look at them. So this is of interest. This is what we're looking at the moment, and it's not. I hope it's not too duff a note to end on, but yeah, just things we're considering within the MS Registry and the SAIL team. Thank you very much.